Okay, if the panelists can switch on their videos, that'll be great, and audios. And I know we're running a little bit behind, but we still have about 20 minutes for nice discussion. So again, the theme for this section was team building and setting up limb reconstruction practice. And I really enjoyed the broad spectrum. So maybe, let me ask for Harihar and Four, and of course others can chime in. Angal mentioned this word jugaad, which to me is like a frugal innovation in a way with creative thinking. And then, there's this concept of reverse innovation. Anir mentioned reverse fellowship, but I feel like there is reverse innovation where so-called well-resourced countries can learn a lot from low and middle-income countries. But somehow that platform isn't as easily available, or there's not much traction. I mean, there's some traction in the economic sector, but not so much, at least in our field. So how do we get it to that level? Any thoughts, ideas? So the question is, like this is a great example, I feel like, with panelists from all parts of the globe kind of sharing thoughts. But how do we make it more mainstream? And how does the high-income country center understand the unused resources and experience that are there in low and middle-income countries? And I think some of us have lived both worlds, and they see that as a lost opportunity.
I think one of the simplest things that can be done is people like us who can interact, who know each other. Fellowship system where, for example, in high-income countries where you are, you establish, a 4-month, 6-month people who've done fellowships with other people in low-income countries. So therefore, you get somebody who's kind of relatively trained, who then gets also to see the other side of things and is exposed to stuff like that. Now you could do that with a minimum stipend, which a living stipend, not a salary. But that's a huge thing for somebody who can come there, spend maybe 4 months, and if each center sets up a 4-month or something like that, 1 or 2 fellowships in a year. For example, the fellowship I did with Dr. Paley was a so-called international fellowship, where I had to pay nothing, but I didn't get paid anything. I had to spend for staying and stuff like that, which was okay. The fellowship I did with Dr. Ranawat was the same, funded by the Ranawat Foundation. They didn't give us any large amounts, but there was like a living stipend, so you could stay close to the hospital. That is a huge thing, I think. There are n number of, like, I have now, there have been around 30 fellows who've gone through our program who've done 1-year fellowships. Now, when these guys have finished 1 year, if they get 4 months to 6 months, to go abroad and see other people working, and the reverse can also work. When I don't know whether people who are there would be interested in coming and seeing how things work here, but if that can, if there are people who are interested, we are the people who can be the bridge.
Yeah, no, that's true. And I mean,
one of your fellows says that I'd like to go.
Go ahead. No, sorry, I didn't mean to interrupt. Go ahead.
So if one of your people wants to come, then 5, 6, 7, 10 people in lower income countries, and you can say, okay, this is this guy is my fellow, he's good. Please take him on for, and that's it. That is what I think really works. These personal recommendations is what is most important.
Yeah, and just to kind of reinforce that, at UCSF they've had, like, there's the trainees, the residents go to other centers, low middle income countries, and they really come back with a change in attitude. Even if they never work in another low middle income country, I think their empathy, their cultural sensitivity increases. Great. Anir has his hand up. Anir, please.
Yes, so from my experience, I think one of the most important things about getting trained as a limb deformity surgeon is getting hands-on experience. And I've done fellowships in continental Europe and in North America. And of course, the biggest problem is that hands-on experience. In the US, you kind of need licensing, and it's there's no distinction with a specific specialty-based experience versus general licensing. And I think if that changes, I think it would be very impactful in getting this north-south transfer of skill and knowledge going. In continental Europe, that model works. So I went to do a fellowship in Austria, and I didn't have to go through licensing exams and all of that. Of course, I was not working independently. I got to scrub in and assist at surgeries, and there is something about observing at close quarters. You get you get a lot more learning experience from that, rather than just being in the room and seeing a procedure done. So I think if there's some way to overcome the licensing obstacle and have some specific pathway to licensing that allows you to scrub in and assist, certainly not to be an independent surgeon, it would bolster the north-south transfer of skill and knowledge. And of course, the other thing Dr. Manga Pareha mentioned about the reverse fellowship, I think the problem with that is it's difficult for a surgeon practicing in the US to leave his practice and spend 6 months or 1 year sabbatical in, say, Nigeria or Cameroon, something like that. If there was some way to, make that a reality, that would also help. So these are things that I think, would further that transfer of knowledge.
Yeah, that's
Thank
good.
you.
And just thank you, Neer. Those are really insightful comments. And just for the record, our next session post-lunch is on this exact same theme of teaching and training in austere environments. But let me just say one thing before I give it to Mangal. The Canadians are actually much ahead than the Americans in terms of allowing overseas visitors. So, and I know Reggie could probably speak to it. So I think that's an area where I think we could, but it takes a lot of legislation and administrative burden to sort of get over it. So Mangal, you had a thought?
Yeah, no, I was kind of underlining what Anir said in the sense that because hands-on is required. So then if someone is, the preparatory groundwork is done back home, so to speak, and then comes there, then observation gives a certain polish. That's number one. Number two, I guess things have changed now. When I was there, I didn't have a license, but we were under some particular category of health visitor or something, I don't remember. And in one of the fellowships, the surgeon, it was Dr. Anawat, where we didn't go on the books, basically. So we could be scrubbed, but we didn't go on to the whatever register. I guess that probably is not possible now, or things have changed and stuff.
Too much oversight. Almost it's become too much of a bubble. Maybe I'll ask Scott, because Scott's got a unique experience where he sort of is the one who's now in Haiti, and in a way he's kind of embedded there. So Scott, what's your take on, the theme of this section was team building. So maybe you can share your experiences about your experience with team building, the wins and losses, and then, the stuff we're talking about in terms of what's appropriate training and your experience in Haiti.
Oh, yeah, sorry, I had to step out for a minute for a team with our meeting in Haiti. And in spite of all the problems there, surgery is continuing there. It's exciting to see that going on. And for myself, it's a real tragedy that the security situation isn't better, because it's such an opportunity for learning. And we're in a location where there's lots of difficult and challenging pathology that you see in many countries around the world, and even occasionally in the United States. And we've had a teaching program at our hospital with local residents as well as residents from the United States. I had a fellow as well that spent a year with me that was from Loma Linda after finishing residency, and also another fellow from Haiti that's now working in the northern part of the country. So the joy of one of the joys of working outside the United States is having less of this oversight and allowing more firsthand experiences. And I can say, if the security situation in our country were better, it would be an amazing experience, as I'm sure it is in Mumbai and some other places, for people from some of these other countries to come and learn and have a really rich academic interchange. And I think it's an opportunity that we don't really have in the United States. We need to keep pushing for it. And I think there's possibilities to make it better in certain ways, but there's also a lot of barriers to it.
Yeah, that's great. The other thing I thought would be interesting is, people talk about the North-South relationship, where, let's say, somebody from a low middle income country comes to a high income country for training versus a South-South relationship and, traveling. And we did a little survey where it was interesting that people in the South somehow would still prefer, some of them, to come to the North than to go to another country with similar environment, similar pathology, similar resources. So I wonder if that's one, true, and number two, is that a good thing or a bad thing? Should we encourage more South-South partnerships and let high-income countries just be a conduit and a platform, if they can't sort of have people scrub in cases?
Yeah, I can tell you that for the fellow that we had from Haiti, for him to come and work at our hospital with us for 6 months before going into practice in the northern part of the country was far more valuable than any experience that we could have given him in the United States. He was working in an environment where he sees similar types of problems, where he sees resources gathered with available technology. I mean, a lot of it at our hospital does come from the foreign sources, but it was a practical approach to taking care of problems in this environment. I think, of course, we all like to travel to different countries and see different things, and so we shouldn't necessarily dampen the opportunities for that. But I would say that really, for a practical learning experience, some of these quote South-South opportunities, especially the ones that are a little bit longer term and where you have a lot of hands-on. And our hospital now is creating a network around the entire country of Haiti for these residents that have spent time with us, people that have done fellowships with us, to use us as a source of referral for difficult cases, a source of certain supplies and materials that we can have interchange, getting advice. When we have relationships with each other, that's much more effective as well.
Okay, Anir has his hand up. Anir, please go ahead.
Yeah, and I think just to stress the importance of the North-South relationship and not to diminish the value of the South-South relationship. So the North-South relationship, you are essentially observing the ideal, the tip of the spear, if I can use that phrase to refer to what limb reconstruction is all about. And in that setting, you're able to walk through your mind, what's going on, and then think back to your own local environment and see how you can modify what you're seeing. So the ideal, essentially, and how you can modify this back home. So I think both models are very good, but I don't, I will not go so far as saying one is better than the other. I think they both have important contributions to the narrative about training and things like that.
Maybe I'll put Chris on the spot. And so Anir, you and Chris have like now a nice north-south relationship in the north. So what do you think, Chris? How has having Anir by your side, changed your practice, your mindset, if in any way?
Well, I'm just privileged to work with a fully trained expert limb reconstruction surgeon by my side. So he can provide perspective from his experience. And, obviously he has a different background than I do. So he often can come up with creative solutions or different ideas that I may not, because I just don't share the same experience. So I just think exposing yourself to as many different places as possible helps your education. So whether it's north-south or south-south, but just the opportunity to work with different people in different environments is always going to improve yourself. So I think visiting other people or visiting other countries is something that we should all do as part of our practice.
Yeah, no, absolutely. And I think the other part that sort of came up earlier, I think it was Anir. So people who have more time for the reverse visitation are people who are sort of slowing down their career, but are still healthy enough to travel. And I think, some programs are trying to sort of target that audience who have, great experience and don't have all the clinical responsibilities. And there's a nice way to ease into retirement. So there's a comment in QA. All right, go ahead. What's the
Yeah, it's more like a comment, I think, than a question, but just a surgeon from Latin America noting that in order to do a fellowship in the United States, you have to take the USMLE, which is obviously a big obstacle, even if they're not going to stay in practice here.
Yeah, and I think, Jackie is involved with LLRS and the traveling fellowship. So a plug for LLRS that they host, and I know Anir did that, and so did some of other surgeons, where you could apply as an international traveling fellow through LLRS and other societies. CCOT has one too. So that's another way to at least get some experience, and some of that is funded, at least partially. Okay, I'm getting a message. It's 3-minute warning for lunch. Does anybody have other thoughts or comments? If
Did you want to send out the panel questions for this?
It's okay. It's okay. Yeah, the polling ones, I kind of thought about it, but sure. So, are people, I can't see it on my end, but okay, here's the question we asked. What additional personnel would be most helpful for building a limb deformity practice? And I guess the majority, or a third, said an APP, an advanced practice provider, PA, or a nurse. 14% said physical therapist, another 14, another orthopedic surgeon. So actually that is worthy of discussion for another time, I think. But that's insightful. Okay, sounds good. I think it's time for lunch, a lunch break rather. Some people, and I realize, some audience and panel members, it's past your bedtime, so I really appreciate that. But we'll be coming back in about half an hour at Pacific time, 11 a.m. for the next talk. So actually start a minute early for the third session, which is on teaching and training limb reconstruction in austere environments. And it'll be a great session. Okay, thanks guys. Great session. Take care. Bye-bye.